better understand what someone else is going through. And I think that maybe helps us start thinking that way.
Absolutely. Thank you for that, Tara. I think regardless of race, ethnicity, age, or socioeconomic status, if you're a mom, you feel that mom connection. If you're a woman, you feel that woman connection, right? That's the beauty of the human connection.
I thought back to the initial encounter with the doctor. When she stated that something was wrong, she was basically dismissed. And we all know everyone's body is different. Everyone's pregnancy is different. So, I basically, was horrified by the fact that she was stating that she was feeling something and she was ignored. Her feelings were ignored.
Yeah. Nichelle, you must be on this panel too, because that's exactly why we're here today, because we want women, especially women of color, who often feel unheard and invisible, to be heard, to do just that. And we believe that that starts with conversations like this, education and empowerment. So thank you so much. That was the perfect segue. I'm going to go back to sharing because I want to run through and level set with some definitions with you guys, just to make sure that we're all using the same terms and the same context as we have this conversation. 1 minute. And at any time, please feel free to use the chat box. If you have any new thoughts or ideas that you want to share with the team, please add them to the chat box, because if you're thinking it, I promise you at least 3 others on the call are as well. All right, so let's provide some definitions to really ground our conversations. Maternal mortality, that's the death of a woman during pregnancy, at delivery, or soon after delivery. And according to the CDC, about 700 women die per year due to pregnancy or birth complications. And unfortunately, guys, 2 out of 3 of these deaths are preventable. Hemorrhage remains the leading cause of maternal mortality, accounting for a little over a quarter of these deaths. And there's a similar proportion of maternal deaths were caused indirectly by some pre-existing medical conditions that were either aggravated by the pregnancy or, really exacerbated conditions. And those are things like heart failure, hypertension, sepsis, and even embolisms. Infant mortality is the death of an infant before his or her first birthday. And in 2019, we lost nearly 6 babies for every 1,000 that were born in the United States. That equates, guys, to 21,000 babies we lost in 2018. 21,000 babies. And the leading causes of these deaths were birth defects, preterm birth and low birth weight, maternal pregnancy complications, sudden infant death syndrome, and even accidental injuries like suffocation. We also, in the United States, we have the highest maternal death rate of most developed countries, weirdly. And when we unpeel that onion, we find that these rates are significantly different for women of color. There are wide disparities for Black and American Indian women, women over age 40, and even women living with chronic diseases. Nationally, Black and Native American women have significantly higher maternal mortality rates compared to their white and Hispanic peers. And this is also true for Black moms here in South Carolina. In the USA, the average age for which women bear their first child has advanced from 21 years old in 1970 till almost 27 years old now in 2018. Yet the average age of motherhood varies by the region of the country, your educational level, and even your marital status. Women in big cities, women with college degrees, and even those that are married tend to have an older pregnancy age, pushing them closer to or at 30 years old. And just as we've seen with COVID, people living with chronic conditions are at an elevated risk for pregnancy complications. National rates for babies of color reflect the same. In 2018, infant mortality rates by race and ethnicity are shown right here on your screen. And in South Carolina, the infant mortality rate decreased, go South Carolina, from 7.2 infant deaths per 1,000 live births to 6.9 infant deaths per 1,000 live births. Now, that only equates to, or that equates, I shouldn't say only, that equates to 26 fewer deaths between those years. And it may not seem statistically significant, but I'm sure it's so very significant for those moms that took babies home and for the 26 who could not. And yet still, South Carolina mirrors the national infant mortality disparities. In 2019, infants of color in South Carolina died at a rate that was 2.4 times higher than that of their white peers. And if we had time to dive deeper into the statistics, which I really enjoy, it would show that education and socioeconomic status really have no bearing. On the screen, we have 3 celebrity women of color that share their own stories of pregnancy and birth complications. In fact, Serena Williams was quoted by CNN saying, "While I have a pretty easy pregnancy, my daughter was born by emergency C-section after her heart rate dropped dramatically during contractions. The surgery went smoothly. Before I knew it, Olympia was in my arms. It was the most amazing feeling I've ever experienced in my life. But what followed just 24 hours after giving birth were 6 days of uncertainty." Now, Serena considered herself fortunate, and we know that many women are not. So if the infant mortality rate is indeed a marker of overall health for our society, as the CDC suggests, we got a lot of work to do. And there is no one better suited to help us start this work than the women that we have featured on our panel today. Dr. Kanasha Glitten, she's an OBGYN here in Charleston, South Carolina, and the founder of the Epicenter, which is a beautiful establishment she just opened. And she's also medical director for Natalist. And then we have Dr. Ebony Hilton, anesthesiologist and critical care physician at the University of Virginia, Charlottesville. And she's also the medical director and co-founder of Good Stock Consulting. Please, without further ado, I will hush my mouth to introduce and allow space for Dr. Glitten and Dr. Hilton. Thank you, ladies, for joining us. And I'll stop sharing at this time.
Thank you for having us.
So Dr. Glitten, let's start with you. Let's talk about why this conversation is so important in the work that you're doing personally and through the Epicenter.
I think you're muted.
Dr. Glitten, you're muted.
Unmute. Can you hear me? Can you hear me? Okay, perfect. Thank you. Well, thank you so much for having me, and thank you to Kim and Mandy for making sure that this came to be, because it's so important and such a worthy topic. I've been practicing OBGYN for the last 10 years now, I guess, after residency, and I realize more than ever that it's worthy of our discussion and our attention. We know that since 2013, 50% of births in the United States have been to women of color. So it's a huge deal, and it's something that requires attention. And I practiced at Roper St. Francis for, I guess, up until 2 months ago. And then I started the Epicenter, and I did so because I feel, and we feel at the Epicenter, that every woman deserves first-class medical care in a setting that represents a haven, though, for women to get their spiritual needs, their emotional needs, physical needs, their perceptual needs, all of those paid attention to and recognized. And so that's why we wanted to be a little more unique and start this center. I've had amazing support from the community, family, friends, Roper St. Francis, and I've really been honored to carry out this vision for our patients. But it's important because we know that many patients have distrust within systems, larger systems. Many of them, just as shown in that video, suffer from social determinants that affect their health outcomes. And unless we figure out a way to provide care that represents non-traditional care that's going to affect outcomes, then we're not really being effective. And the whole reason we're practicing medicine is to be effective and have improved outcomes. So I'm really thankful to be a representative of the Epicenter. In addition, I am the medical director of Natalist, which is another company that really focuses on providing beautiful science-backed fertility and pregnancy products in a way that basically helps women achieve their dreams of pregnancy. In addition, though, what I'm most proud of with that company is that we also offer science-backed information. Like, I write articles for this company and other consultants do as well, but we are required to back our information by science. And so many sources don't require that. So the information that's on our site is definitely scientifically backed, and I feel proud to be affiliated with that company.
Thank you for that great introduction.
Yeah.
Dr. Hilton, tell us about why you believe this conversation is so important and some of the work you're doing in this space.
Yeah, so thank you again, Kim, for even having me and inviting me to be on with Dr. Glitten, who I send everyone to. If there's any question about OBGYN or related, is Dr. Glitten has the answer. But it really is one of those things, you know, I came into medicine because when I was 8 years old, my little sister asked my mom if we could have a little brother. And it was at that time that she told us that her first child was actually a little boy, that she went in for prenatal visit. She had a sharp pain during that visit. They sent her home and she immediately started leaking fluid, and she was 6 months pregnant with her first kid. She calls and she says, you know, I'm leaking fluid. Is this normal? Like, what should I do? And they say, oh, it's normal. Go on, it'll be fine. And she ended up going into labor. And my brother lived for 3 days before he passed away. That was the first time I've ever seen my mom cry, and to see that woman of strength be brought to literally her knees and recounting this story made me think, as an 8-year-old, I want to be involved in a process that will prevent anyone from having to go through that level of hurt. And so in growing up in medicine, it's been very troubling, to be honest with you, to know that our health disparities have not changed. And that although my mom was 17 when she lost my brother, me at this age of life, with 13 years after high school of education, my child is more likely to die than hers. My child is literally twice as likely to die than a white woman with a 3rd grade education. My child with a woman at my same level of education who happens to be white is 5 to 7 times more likely to die than hers. The fact that 1 in every 90 Black children born will die before their first birthday. The fact that 1 out of every 2,000 Black women, pregnant women in the United States, can expect to die in the peripartum period, that's a problem. And it's a problem that never gets mentioned. And it's not only in terms of birth and birth outcomes, but it's also heart disease for Black women. It's, you know, it's also, you know, these conditions that led to us being more likely to die from COVID-19, right? It's also the fact, if we're looking right now with COVID, that 1 out of every 13 COVID deaths has left a child orphaned at this point. 1 out of every 13, right? And if we're looking at it in terms of race, we know that Black children only make up 14% of the population, but there are 20% of those kids who are now orphaned because of COVID. It's a problem. And we need to stop speaking the same problems and start tackling with solutions and having some accountability tied to why is it? Because it's not that we're weak. It's not that something is wrong with us. The system is flawed and is set up to be a disadvantage. So how do we tackle that system? Which is what we do at Good Stop. So yeah, so that's it.
Thank you, Dr. Hilton. Those are great stats and facts. I see that Sarah added to the chat box. In South Carolina, we have about 400 infant deaths per year and 14 maternal deaths per year. So we can say we lose a baby every day in this state and a mom every month. So much loss.
Wow.
And
no mention. That's the crazy part.
Absolutely. So now that you know exactly who our featured panelists are, we're going to open the floor for question and answer. We want this to be a casual conversation and dialogue about something that we obviously all care about because we're here today. And so we don't want to clog the time with just presentations, but we want you to have an opportunity to speak to these so personable physicians about a condition that they spend most of their time on. And I'll kick the questions off with one. If both of you could share an experience with us, I'm interested in knowing if you've ever seen inequities in action, either in practice or even during your training and residency. Have you ever witnessed another physician or colleague engage with a patient in a way that you knew was inequitable? How did that make you? Did I blink out?
Absolutely. So I think we can both tag team this, Ebony, because I know we went to medical school both at MUSC. So we have similar training and education in that regard. But I do remember that we had a doctoring course where we had basically patients that were acting as real patients. And so we learned a little bit about implicit bias and stereotypes and social determinants. But I will tell you that that portion of our education was so small that I barely remember it. I can't remember who taught it. I can't remember whether we were tested on it. And so, to be honest, it's a huge deal because not only should it be incorporated into medical education as well as residency, I feel that there should be active training and helping us identify implicit bias. I think the problem with implicit bias is that it's unconscious. So you don't know that you're biased because you're not aware of this, as opposed to explicit. And so I think the fact that we're unaware, if no one brings it to our attention, then we're not able to change things in terms of affecting our outcomes. So very little, in my opinion.
Right. And I think we need to push it even a step further past education, right? Because yes, we need to do those training modules, but there needs to be accountability and metrics that we can follow. And in medicine, there are easy metrics that we could follow to have some accountability tied to things, right? There are studies that are being published, and I'll try to find actually the link to it. But there are studies looking at babies who are born prematurely. Sorry, my little camera is freezing up. But babies that are born prematurely, whether or not they receive steroids. And we know that when babies are born premature, they have underdeveloped lungs, and that steroids helps the process of their lungs being ready to take oxygen and not rely on this placenta, right, before birthing. And what studies show was that if you are a Black or brown baby born prematurely, you are less likely to get steroids. How is that possible? And that's a metric, again, that's easily tracked. And so what's the accountability tied to it when we're not giving that intervention that can literally change the trajectory of this child's life from being one of 90 that has died from prematurity or birth complications to one that has lived? How are we making sure that we're not just saying the same words without action steps? Because now we've been saying these words literally since 1619. How do we make sure now that if this message isn't getting across, that it's not costing someone their life on the other end of it? That's what we need to stop.
Absolutely.
Sorry, I had a video glitch before. We have a question in the chat box. Are there other states we can look to that have implemented state level change or policy that has moved the needle on reducing maternal mortality among Black women?
I'll take this one. I definitely think there are. And I think a model state has been California. So California
I just wanted to make sure you brought masks.
California has definitely moved that needle in a very positive way. And I think that it definitely serves as a beacon for other states to take notice of. They have reduced their postpartum hemorrhage significantly and developed protocols and bundles that many states across the country have been able to implement. I'm proud to say that Roper St. Francis has also implemented a bundle, which is supported by ACOG as well as the American Initiative on Maternal Health, to basically reduce and better determine what constitutes a postpartum hemorrhage, but also reducing the complications, because we know that certainly is a significant contributor to maternal morbidity and mortality. So I think that there are protocols and paradigms out there. I think, though, if your healthcare system if this is not on the radar, then nothing ever will change. So I think the important thing is, like Ebony said, education, awareness, but also a tracking system to ensure that, okay, there's going to be some advocacy, but also some action behind it. Because again, we're not here to look at statistics and data collection. We want to know how we can affect outcomes and, again, save mothers' lives as well as babies and infants.
You guys have mentioned COVID a few times, and then Crystal Davis just added to the chat that she saw in an Instagram post this morning. It stated that maternal mortality rate has surpassed that of COVID-19. So given the work and the experience that you guys have had with COVID, what are some lessons learned that we can then apply to this similar or comparable epidemic?
I think one of the biggest things with COVID is, we know, as far as Black people, we already knew, I think the majority of us knew that Black people were going to be hit worse. Black and brown communities were going to be hit worse because we have higher death rates. Literally, of 9 of the 15 leading causes of death before COVID, Black people had higher death rates, right? We die not only at higher rates, but at younger ages. Black women, for instance, although we're less likely to be diagnosed with breast cancer, we have higher death rates in literally every single state of the United States of America, dying at more aggressive disease processes. And so I think, I'm hoping, because of the impact of COVID and the rate by which everyone has been dying, unfortunately, and the massive casualties that we've had associated with it, that we'll start taking an approach of where we're addressing racial health disparities from the foundation up. Let's start fixing the system, right? Everything that leads to a person being more likely to die. And if we address those systems, lack of access, the influences of your zip code being a more important determinant than your genetic code, right? And all the factors that go into the social determinants of health and lack of resources, then that will trickle down in our trying to fix what COVID showed, will trickle down to Black women being able to stay alive to take care of their families. Will trickle down to our kids being able to see their second and third birthday. Yeah, and to hold, again, systems accountable, knowing that it's not a person's fault that, with COVID, we're seeing the people that are more likely to be infected are the ones that are essential workers having to go to work, right? And what does that same stress do to a pregnant woman, where you have one of these essential jobs where you're not making a livable wage, so you're working 2 or 3 jobs at a time, and you're on your feet all day, and you're 7 months pregnant? Is that why Black women are 50% more likely to go into preterm labor, right? What does that mean to a woman that's carrying the next generation of our country? Holding that as being important, I hope, is what comes of this. So,
Absolutely.
I just thought in my head, can Black women afford to be pregnant? Can Black and brown women afford to be pregnant in America?
No.
Kim?
No.
Yeah, Dr. Foster.
Hey, good afternoon, everyone.
Oh.
Hey, Ebony, how you doing? It's Rick Foster.
Hey.
Hey, so I want to build on this discussion. This is so important. And both the issue around the training and exposure for students and residents and clinicians in general, and the fact that while there is a classroom component I think we can incorporate, and I'm hoping that more and more medical schools and academic centers will do that. To me, there's also the experiential learning. If you can speak to the fact that we've got to create opportunities for clinicians and senior leaders to have a better understanding of what the factors are and what they could do to make a difference. And with that said, I would like for both of you to maybe speak more about how do we better engage senior leaders. I think we've got more awareness than ever before of the gaps and some of the factors, including racism and other social determinants, but actually turning that awareness into action. What else can we be doing? Because I think until we get senior leaders engaged, you're not going to have change in the curriculum. You're not going to have change in the way we reach out to certain communities. And that's the thing I wrestle with the most. I will say on the vaccination front in general, here in Charleston, and Kim's very aware of this too, Roper and Fetter and MUSC, they realize when they go out and work with the faith-based community and the churches and other community-based organizations, hesitancy for vaccination becomes much less of a problem among the African-American community because they have trusted voices. Mm-hmm. And they're doing an amazing job of getting vaccines to people that otherwise couldn't get access. So we've got examples where we can make a difference, but it requires senior leaders making a different level of commitment. So can both of you speak kind of to what else could we be doing to get senior leaders to move from, oh, this is a real problem, to doing something about it?
I think the first thing is that the senior leaders need to look like us. I mean, quite frankly, the senior leaders are usually white men. And even when you're looking at different departments, and Dr. Glitten, maybe you can chime in on this with Roper, but at MUSC, when I was there, I was the first Black female anesthesiologist. Here at UVA, at the University of Virginia, I'm the first Black female anesthesiologist. And diversity matters. Literally, I can put another study in the chat that shows where Black women, if you have a Black OBGYN, your likelihood of bringing your child home alive increases, just along the lines of race. Same things are with surgical outcomes. And oftentimes, we really got to start looking at, I don't know, Roper, what your diversity panel looks like, but who are in those positions, the policy makers, when you're thinking about rolling out these initiatives, do you have representation of persons at the table, and not as just a member, but literally as a leader to organize and think about the the strategic
Let's
plan.
go. You talking about?
Uh-oh. And then another thing I think is also the leaders need to recognize when to speak and when to listen, and bringing members of the population that we are talking about, Black women. If you're talking about why we're dying, then let us tell you. We already know. And that community is not like that we are impaired. We're not empowered. Let our voices be the reasons. If we have to navigate the system, we automatically know exactly where the flaws of the system are. We automatically know exactly what keeps us from being able to get access. We automatically can tell you, yeah, there's a lack of communication. There's a lack of access within my community. I couldn't pay for it. I couldn't find the time because you only have hours from this time to this time, and I'm working 3 jobs, and you don't have a daycare center, and I have to bring my children with me. We know the problems, but rarely, if ever, when we're talking about vaccine rollout, rarely, if ever, we get a community leader, a community person on the board to say, now you tell us. If we're talking about putting this on the internet, does that make sense to you? No. Why? Because we don't go to your site, okay? We don't navigate that way. You can talk to this person, this person, and this person, and this is how we can come up with a plan that will save you 4 or 5 weeks of development and a waste of time. But truly, the people that are usually in charge of making decisions for Black and Brown communities look absolutely nothing like Black and Brown people. And even when it comes down to maternal health, it's just, we're not included. Kanasha, sorry. Go ahead.
Yeah, no, I think that was well said, Ebony. And some of those words are hard to hear, but they still remain and ring true. And I think, honestly, I'm glad that Dr. Foster is wanting to engage that conversation, because that's the first step. I think you have to have someone that actually cares about it. So you're exactly right. Like, even in my world, we have known that traditional prenatal care for the last 100 years has not improved outcomes. We have the worst outcomes of all nations. And it's really a focus of understanding that not only do we have worse outcomes, but we have systems in place that can improve those outcomes, right? And I think of one called Centering Healthcare, which I'm very passionate about, for centering pregnancy. And the whole reason why the Epicenter was created in terms of centering, because we have a proven model of prenatal care that we know can reduce the risk of preterm birth by 36 to 40%, can increase patient engagement, increase physician engagement, increase breastfeeding rates, decrease low birth weights. And we know these are reasons why Black babies die more often than white. So we have a proven system. Studies are out there. Multiple studies have been done. But if you look at most healthcare systems, that centering model or even option for patients doesn't exist. And so I think not only do you have to recognize these things, but when something is proven, I think you have to ask your system, if diversity issues are important, then why aren't we implementing tools and models that have been proven to increase diversity? So I think you have to care. I think that's the important thing. And you're right. I think we have to get those folks who care in those roles of power so that we can kind of move the needle in the right direction.
Mm-hmm. Thank you guys for being so brave and calling those out. I'll make sure that leadership listens to this recording after we're done today. I want to acknowledge the comments in the chat. Zipporia, she put in there that she's with the South Carolina Birth Outcomes Initiative. Hey, Zipporia. And South Carolina recently became an AIM state. We will be working with hospital champions in all South Carolina birthing hospitals on the various safety bundles. And then I believe a colleague put their email address for DHHS here in the state. If anyone's interested in joining that initiative or learning more about it, please check your chat box for conversation or for contact information for more information. Ginger mentioned in the chat, she wanted to know if we believe, or if you two believe, that the lack of Medicaid expansion impacts mothers and babies in this state of South Carolina. We know that there's a new legislation that Biden introduced, or new-ish, that gives even more incentives to the 12 states that did not expand Medicaid. So what could South Carolina or even the South look like if we took a hold of that initiative?
You want to take that first, Kanasha?
Yeah, absolutely. I think that the expansion of Medicaid, just being realistic, that's certainly never a bad thing in terms of allowing more access, as well as just adequate resources for people of color. And so we certainly know that there is a large percentage of women of color who rely on Medicaid, certainly because of a long-standing history of inadequate access and resources. And so that system in place certainly will improve access. I think there's so many postpartum and pregnancy-related ailments that could be helped by, just expanding Medicaid and making sure that women have paid maternity leave and that women have access to Medicaid for up to a year after birth, so all those things that we know ultimately affect whether patients are readmitted into the hospital. Oh, sorry. Can y'all hear me?
Yes.
Sorry, whether patients are readmitted and what their outcomes are ultimately are affected by those financial incentives and those resources that patients don't normally have. And so I definitely think that certainly is not a bad idea and should have been implemented for sure.
And I think to add on to that too, Kanasha, maybe you can speak to this about the coverage. We know that maternal outcomes are tracked up to a year after the baby is born, but yet insurance only covers, is it in South Carolina, 8 weeks or 6?
6 to 8 weeks, depending upon mode of delivery. Absolutely.
And tell me why. Again, that lets me know that the person that made that determination was likely not a mother or not a woman who can tell you that my body is not back to normal in 6 to 8 weeks. Anesthetically, I'm an anesthesiologist. We literally say for women, if we're going to do a tubal, tie your tubes, if you're having general anesthesia, we have to wait at least 6 weeks because your body is at higher risk of having a bad outcome with general anesthetic if it's before then. So we say we have to push you off until your body gets to somewhat normal function as far as your GI tract. So to tell a woman, and that's if you have insurance coverage, which we know in South Carolina, we have a large proportion of our citizens that are not covered with insurance, and women are going back to work within a week of having a human come and being delivered. What does that do to the incidence of postpartum depression? What does that do to the incidence of development of cardiovascular disease, heart disease, lung disease? What does that do to the overall, development and nourishment of a newborn child? The stress it places on families. We're not supporting holistically that bonding process and the healing process that has to undergo. And insurance is directly linked to a lot of that, right? Yeah, it's a lot to think about.
And the U.S., I learned this too recently, the U.S. is one of only 3 countries that does not have paid maternity leave. I had no idea, one of 3. And so it's really nearly shameful for our many of our moms to go back to work at 1 to 2 weeks just because they don't have any income coming in. If you don't have income, you can't pay your rent. You don't have $5,000 to $10,000 in the bank just as a reserve, So all of those things disproportionately affect, women of color and are affecting their decisions to maybe go back to work when their blood pressure is still too high and undergo more stress and then come back with an eclamptic seizure or various things that are happening. So it really is a cyclical effect.
Mm-hmm.
I think it's important for everyone to know, this is Dr. Foster again, that with the American Rescue Act, and y'all have touched on it, that there's an opportunity for states to fully expand Medicaid coverage, even for existing Medicaid recipients, to the full 12 months for women postpartum. Mm-hmm. We need to have a strong collective voice to support that. I'd love to see the full Medicaid expansion, but realistically, I think when we have the best chance for making a difference is to get the expanded coverage 12-month postpartum. It doesn't make any sense at all, as you said, that we don't have that coverage. And then we need to look at other steps that need to be taken. I also wanted to congratulate you for bringing up centering pregnancy. It seems to me a lot of the solutions here are what I call low tech, high touch. In healthcare, we've traditionally always focused most on the high tech. And now we need to realize that centering and doulas and community health workers and those kinds of outreach efforts, we've got data that shows it can actually make a significant difference in improving outcomes for moms and baby. We've just got to get leaders to invest in those types of what I call low tech, high touch solutions. And I commend you for being an advocate for that.
Mm-hmm. Dr. Foster, you're absolutely right. In fact, our chat box is blowing up about doulas. And I love that. We're in fact going to talk about doulas in week 3 with a doula that we'll have featured on the panel. But I do want to give it space since we have some conversation about it in the chat. Dr. Glitten, I know that you've talked about including doulas in your practice at the Epicenter. Tell me how you see that, how you envision you working alongside doulas and midwives.
Absolutely. So certainly we are always thankful to have extensions of our ability to touch and improve outcomes for patients. And doulas are just that. So they are basically patient advocates who can answer questions and be a source of support and be there typically in non-COVID days during the delivery process. And that's really when patients have the most questions and they need that support. Many women of color often don't have extended family that can take off and spend 2 or 3 days with them in the hospital. And so certainly doulas are integral in doing that. But we have studies, like Dr. Foster said, we have studies that show that doulas help improve outcomes for women of color and women in general. So we know that outcomes are better when women have this extra source of support. So I definitely am excited to incorporate those into, and even in terms of prenatal education and training, because a lot of things that happen start during the pregnancy, you know, like the birth is not just it's just the highlight, but during the pregnancy, those decisions that women make regarding whether they're going to eat this versus that, and whether they're going to check their blood pressure and be compliant and come to their appointments, all those things ultimately affect the outcome and the postpartum complications. So definitely doulas are advocates for us.
Yeah, and it's one of those things too, and thinking again of who's making these policies. If you're having a knee operation, we know that physical therapy is covered, right? The rehab is covered as part of the package of you needing that intervention. If we know that midwives and doulas have improved outcomes for women being able to stay alive and for babies for being able to stay alive, then why isn't that automatically one of those things that's tied to your package of when you're going to see your OBGYN? Here's your PT or your OT
Absolutely.
of birth, right? And pushing, you know, when Dr. Foster mentioned about Medicaid expansion, we know that back in, I think I went to speak to Governor Haley in 2000 and whatever that was year about Medicaid expansion, of which South Carolina passed on, right? We have to really push and say that at the other end of us passing on expansion of these packages for statewide, that on the other end of that, there's complications with our people, our neighbors, and any one of us can be the next one of that statistic, right? So, and I think anything that COVID shows is that when we don't take care of the foundation, the majority of persons that fall into this group, the entire system has potential to crumble. And that's what we see over and over again in South Carolina. We have brilliant, smart, caring people, right? So why are we ranked 35th in overall health outcomes? Why are we having these disparities that we see over and over again in terms of health, wealth, education? We don't have to. We just need to really lean in and say, how do we stop making the same mistakes over and over again? So,
thank you guys for that. Holly asked, she wanted to know what we're doing at Roper St. Francis to recruit and hire more healthcare providers from the BIPOC community, and that's Black, Indigenous, or other people of color. She's read studies that show that having providers of the same background can significantly improve outcomes and the overall birth experience. Holly, you're exactly right. In fact, we're waiting for our new Chief Diversity Officer to come on in so we can start to mobilize some of the plans that the Diversity and Inclusion Council have already started to work through to see how we can get more of those BIPOC members on our floors, and not just as physicians, but as administrators, as our front line, making sure that we're infused and we certainly represent the community in which we live. I saw Mandy go off mute. Mandy, did you have a question?
I didn't have a question. I wanted to talk about, and I know we're going to discuss it in week 3, as a former doula, now nurse. One of the things that I always admired about some other healthcare systems was they actually had doulas that were employed by the system, that it was asked if they, you know, if a patient came in, you know, they were asked if they would like this, you know, person to hold space for them. And I don't know the financial aspect or anything like that, but I just think, like, you know, as a nurse, I would love to spend that much time with my patient, but unfortunately, you know, there is a financial and productivity aspect for me as a nurse. So I think that, you know, having the opportunity to have access to that sort of care would be great for the system.
Thank you, Mandy, for that comment. And she kind of bleeped out on us. started to sound like a little bit like a robot, but I wanted to give Mandy a shout out because this is actually her child that we birthed. This was her idea. Even as a white woman, she recognized that as a nurse, as a former doula, she knew her responsibility in this community. And so she came to us and said, hey, I have an idea. Can we make it happen? And so thank you guys for tuning in and making this dream come true. But Mandy, you're absolutely right. I think there's truly a multidisciplinary approach that we can have to impacting these disparities. Well, it's 12:50. I'm doing a time check, and I do not want to leave you on. Ginger asked, is there an opportunity for the Wilbur St. Francis Foundation to assist in funding a doula trial? That's certainly something that I can pose to our foundation. And we can talk more about that in week 3, because I truly want to understand. I know that Mandy's corrected me. It's like doulas and midwives are not the same. And so how do we differentiate between the two, and how do we leverage the strengths of both roles in order to improve the birth outcomes of not just our Black and brown women, but for all women, because we all deserve the same level of high quality care. One thing, I want to end on a good note. I want to end on something empowering. If we don't have any other questions from the group, tell me, Dr. Hilton and Dr. Glitten, what's a message that you want to leave us with as women, as men committed to this fight against maternal and infant mortality? What's something that we can start to do even today to start to push a better agenda and better outcomes for our women of color, women and babies of color?
Ash, you want to go first?
Yeah, I think it's just so important that we recognize that these statistics, we hear them so much. I feel like it's almost like a neutralization, like we are just kind of numb to the fact that they can be changed. Like, yeah, we might not see it in a year or two, but if it's collaborative effort, we can change these statistics. So I think if I were a person just in general, like not in healthcare, I would look and see what I can do on a national level in terms of making sure that policy changes happen, and making sure that when I go to the polls, I'm electing folks who are stakeholders in maternal outcomes, and making sure that they're important. If I'm a healthcare provider, I would ask my practice or my healthcare system, what can I do, or what are we doing? And then hold those systems accountable. So certainly if no one's bringing it up, the squeaky wheel gets the oil. If no one's bringing it up, then healthcare systems and practices in general think that it's not important. So I think we have to actively make sure that we're vocal about these things, how they're important, because by 2050, more the minority, or I guess the current minority, will be the majority. Like people of color by 2050 will be the majority. And I think this represents our US population. So it's a big deal, like our communities. And so I think we definitely have to make sure that we make it a priority and not stand by neutrally, but understand that we can change the statistics for sure.
Yeah. And I think, and I completely echo that too. I have this saying that women, we birth nations. So of course we can run one. So I think truly in understanding the power that a woman has, literally we have potential to birth every single type of human being, a boy, a girl, a non-binary, a gay, straight, lesbian, religion, everything. We have that potential in us. And so pushing leadership to have that voice and know that your voice carries weight. Because of the fact, I think, to go back to the movie that we saw in the beginning, the reason why we all had that gut reaction is because we all are linked as women. We feel the pain of that woman, and we can empathize with the situation of, what if that was me, and what does that do? Mm-hmm. So I think there are a lot of important points that people are making in the chat. For one, pushing the leadership to say, what is the diversity of every single department that you have here, right? Surgical department, OBGYN, anesthesia, every department needs to have look like the demographic of the persons that we're serving, right? And then push upwards, literally become one of those persons at the table making the decisions. Trust your voice. And whenever you have a chance to have a seat at the table, make sure you pull another seat up beside you and say, and this is my +1, right? Keep adding to it. Because we really do, as women, I really fully believe we have the solutions within us. So trust that process.
Thank you, ladies. That was truly inspiring. What I wrote down, and Tara just added in the chat, trust your voice. Yes. Love that. And bring a +1. And I wrote down, we can be the change that we want to see, and add a +1. So thank you guys. Yeah. Yes, Dr. Foster.
the old white male in the room, can I say that what encourages me are you three Black female leaders are on this session today. We need many more like you in leadership roles. Ebony, when you decide to run for whatever major office in the future, I'm still around your campaign now.
And at press conference.
That's right. I think that every Black woman should be able to have the option of having a Black physician, including a Black female physician, just like women in general should have the option if they want to have a female OBGYN or midwife. And so we've got to be able to have that. At the same time, we're educating and building cultural humility and awareness among the entire clinical community. So it's both. But I hope that we'll start seeing that more and more. But I'm so encouraged and hopeful based on the three of you as great examples of strong Black female leaders. Thank you.
Thank you, Dr. Foster. Power to the people. And as Renee added in our chat, please continue to share your stories, your birth stories, those that were safe and those that were not so safe, because honestly, the connection is in conversation. Please come back with us. And in the following weeks, next week, we'll speak about what healthcare systems can do. And it sounds like you guys already have some opportunities that you want to discuss with them. So come back when we talk to some physicians that work inside the hospital to learn what we're doing at Roper St. Francis and even systems outside of Roper St. Francis. And then on week 3, we will talk about what the community can do. So we'll introduce our doulas. We'll have Dr. Khan, who is amazing, who works at the Shifa Clinic here in Charleston. And then on week 4, we'll have Dr. Joya Career-Perry. And if you're familiar with this space, then you know that name. She is a powerhouse nationally, and she brings the heat every time she speaks. But that will be our opportunity to learn about laws, policy, advocacy work that you can do from your computer, from the tips of your fingers. So please join us each week. Encourage others to come out as well. And we will see you in 7 days. But thank you guys so much for participating.
Thank you.
Y'all have a good one.
You too. Bye.